Welcome everyone, this is lecture 57. This series of lectures is based on my book, Manual of Fluid, Electrolyte, and Acid-Base Disorders, a pathophysiologic approach to common clinical problems. You can find the book on Amazon at the link below. We will continue our discussion today on metabolic acidosis. Now we are going to talk about diagnosis. I'm going to provide a 6-step approach to diagnose any metabolic acidosis. Doesn't matter how complicated the case is, you will reach the right conclusions if you follow these 6 steps. So let's get started. Step 1, or actually before we even start with step 1, I'm going to remind ourselves with the definition of metabolic acidosis. Metabolic acidosis is a reduction in blood pH, so pH has to be below 7.35. Generally speaking, we'll talk about that some more, due to a reduction in serum bicarbonate. And that is accompanied by a secondary reduction in carbon dioxide arterial pressure, PaCO2. Now, normal values for our discussion, pH 7.4 or between 7.35 to 7.45, that's the normal pH. Bicarbonate 24 and PCO2 or PaCO2 is 40 millimeter of mercury. These are the 6 steps. First, you need to obtain ABGs and electrolyte panel simultaneously. You want to make sure that we fit the definition. If we do, step 2, calculate respiratory compensation. Step 3, calculate the anion gap. This is going to tell you if you have anion gap metabolic acidosis or non-anion gap metabolic acidosis. Next, calculate delta. We'll talk about that. This will tell you if you have a mixed acid-base disorder, more than one disorder at the same time. Then in special circumstances, in special cases of non-anion gap metabolic acidosis, you need to calculate urine anion gap and or urine osmolar gap. And finally, if you're suspecting a toxin, you need to calculate serum osmolar gap. That's the last step, step 6. Let's go. Step 1, obtain arterial blood gases and an electrolyte panel simultaneously. If pH is less than 7.35 and bicarbonate is less than 24, it's low, then you have metabolic acidosis. You cannot just look at serum bicarbonate and say it is low, therefore it's a metabolic acidosis, because low serum bicarbonate can be due to metabolic acidosis or due to respiratory alkalosis. In respiratory alkalosis, the PaCO2, the CO2 is low. Therefore, the renal compensation is low bicarbonate. Okay, so don't be fooled. You need ABGs. Step 2. Okay, so now we met the definition. Now we need to calculate the respiratory compensation and determine if it is appropriate. Now, we calculate this respiratory compensation. If the PaCO2 is below, way below what we calculated, then we probably have respiratory alkalosis, meaning 2 disorders, metabolic acidosis and respiratory alkalosis. Now, if we calculate the PaCO2 and the actual value is way above what we calculated, then we may have respiratory acidosis, meaning 2 disorders, metabolic acidosis and respiratory acidosis. How do we calculate compensation? You have 4 methods. The first method, for each 1 milliequivalent per liter decline in bicarbonate, and we consider normal value 24, for each drop below 24 by 1, there's a 1.2 drop in PaCO2. The second method is probably the preferred and the most famous method, is using the Winter's formula. So the expected PaCO2 is bicarbonate, the bicarbonate that we have, times 1.5 plus 8 and plus minus 2. So you have here some variation. If you're in a real hurry and a little bit sloppy, you can just look at the last 2 digits of the pH, and this is what the expected PaCO2 should be, or you can add 15 to bicarbonate. Okay, the last 2 methods are not very accurate, especially at the extremes of pH. Now, you have to keep in mind that when you have metabolic acidosis, the PaCO2 is low because the patient is hyperventilating. But there's a limit to that. So you cannot get below 10. Okay, the patient cannot blow off so much CO2. So there's a limit. Now, compensation is not complete, meaning if you have metabolic acidosis, so you're calculating a large anion gap and you know you have lactic acidosis, but yet the pH is normal or close to normal, 7.39, 7.4, then you have respiratory alkalosis, meaning it's the irregular compensation, the expected compensation can never normalize the pH. If it's normalized, then you have two disorders. You have metabolic acidosis and respiratory alkalosis. So each kind of pulling in a different direction, and this is why the pH is normal. They cancel each other out. Let's give an example. So we have a patient with metabolic acidosis, pH is 7.29 and bicarbonate 13. First method, for each 1 decline in bicarbonate, there's 1.2 decline in PaCO2. So normal bicarbonate, we said 24 minus 13, which is the actual value. So here we have a decline of 11. We multiply that by 1.2, and the decline in PaCO2 should be by 13. A normal value is considered 40, so 40 minus 13 is 27. All these are approximations. So if it is 27. If the PaCO2 is, say, 40, then you have what? You have respiratory acidosis. And if the PaCO2, when we measured it, is not close to 27, it's 15, then you have respiratory alkalosis. Winter's formula, as you can see on the screen, will give us pretty much the same answer, 27 plus minus 2. If you look at the last 2 digits of the pH on the ABGs, you get 29. Well, it's still within the same range of the Winter's formula, or you add 15 to bicarbonate, which is 13 plus 15 is 28. It's also close. Step 3. Now we need to calculate the anion gap to determine, do we have anion gap metabolic acidosis or non-anion gap metabolic acidosis? So first I have to say that in the serum or the urine, the number of anions equal the numbers of cations. So negative charges equal positive charges. When we talk about a gap, meaning it is something that we cannot measure. We're not measuring. There's no actual gap, okay? The number of positives equal the number of negatives. What is the anion gap? You take the sodium minus the combined value of chloride and bicarbonate, and you get the anion gap. Okay, as you can see on the screen, normal value is about 10, 12 plus minus 2 mol equivalent per liter. Now, if you look at the screen, sodium minus bicarb plus chloride is the same as unmeasured anion minus unmeasured cations. Okay, it's just the flip side. Okay, so this is just a different way of looking at it. Now, unmeasured anions are mostly albumin because albumin has a negative value in addition to some phosphate, sulfate, and IgA. And measured cation are mainly your potassium, your calcium, your magnesium, and IgG. Those have positive charges. So in other words, if you measure everything, you're not going to have an anion gap. And then the positives will equal the negatives. I cannot emphasize that more. Okay, now what happens when we add an acid to the serum? We said that the bicarbonate will buffer the hydrogen. So you have one hydrogen buffered by one bicarbonate, so the bicarbonate will go down by 1. Now what's going to happen to the anion that accompanies the hydrogen? Well, it's going to create that anion gap because we cannot measure it, or we're not measuring it. So in simple anion gap metabolic acidosis, Ag-Ma, the bicarb goes down by 1, then the anion gap will go up by 1. So there's a 1-to-1 relationship. Now, if that anion is excreted in the urine with sodium rather than chloride, which is the normal way, then the chloride is left behind, and here we don't have an anion gap because basically we are replacing that anion with chloride, and in that case we have a non-anion gap metabolic acidosis like you would see with diarrhea. Therefore, we have 2 types of metabolic acidosis. The 2 major types based on anion gap are Ag-Ma, which is also called anion gap, or high anion gap, or organic metabolic acidosis, like you see with lactic acidosis and ketoacidosis, or NAG-Ma, or non-anion gap metabolic acidosis, normal anion gap, non-anion gap hyperchloremic acidosis, or mineral metabolic acidosis. Any of those, okay, can be used. And in that case, like we said, bicarbonate decline is accompanied by an equal rise of chloride. Therefore, the anion gap remains unchanged. Let's look at these diagrams to emphasize the point further. On the far left, you have the normal situation. So anion gap is sodium minus chloride plus bicarbonate. And I marked that in that rectangle within the yellow, within the unmeasured anion. Now look at the middle diagram, anion gap metabolic acidosis. Here, as you can see, the bicarbonate has declined and therefore the anion gap has increased. This is why we call it anion gap metabolic acidosis. Now, in normal anion gap or hyperchloremic acidosis, you can see that the chloride went up, the bicarb still went down, but the anion gap did not change. It's the same as in the normal situation. Now, if you have low albumin, it's going to give you a low anion gap. So for each 1 gram decline in albumin, the anion gap goes down by 2.5. So in other words, if you have an anion gap of 5 and albumin of 2.5, the decline in albumin is from 4.5 to 2.5, so it's by 2. And we said for each gram decline in albumin, anion gap declines by 2.5, then 2.5 times 2 is 5, so then the actual anion gap is 10. In other words, correct the anion gap for low albumin. Okay, so it's going to give you a falsely low anion gap. Now, step 4, determine if the patient has a mixed acid-base disorder. We said that if we measure the PaCO2, if we look at the blood gases and we find that the actual PaCO2 is more than 5 than what we calculated, than what we estimated, then we have respiratory acidosis in addition to metabolic acidosis, like someone in the critical care unit with hypercapnic respiratory failure. You see that all the time. On the other hand, if pH is normal, then you are pulling in different directions. So you have metabolic acidosis and respiratory alkalosis. So one process is bringing pH down, the metabolic acidosis. The other one is bringing the pH up, which is the respiratory alkalosis. So they kind of cancel out. And this is what you see in someone with sepsis and hypoxemic respiratory failure. Now, if we want to kind of dig a little bit deeper into this concept, we should calculate what is called delta-delta, meaning when bicarbonate goes down by 1, like I said, approximately the anion gap will go up by 1. So there's this like 1-to-1 relationship. So if we consider a normal anion gap 10 and a normal bicarb of 24, the delta-delta is measured anion gap minus 10 divided by 24 minus measured serum bicarbonate. And in diabetic ketoacidosis, this relationship is 1. In lactic acidosis, about 1.6 to 1.8. So how are we going to look at that? Okay, just pay attention to the logic, not the numbers. Now, we said that the relationship is pretty much like 1-to-1. So when bicarb goes down by 1, anion gap goes up by 1. What about if we see that the bicarbonate went down, like way down, okay? So anion gap is, say, went from 10 to 17 by 7, but the bicarb didn't go down from 24 to 17. It went down to 10. This is a situation where you have probably both anion gap metabolic acidosis and non-anion gap metabolic acidosis, such as someone with sepsis will get lactic acidosis, so this is anion gap metabolic acidosis, and diarrhea, which will give you non-anion gap metabolic acidosis. Someone with GI fistula will give you non-anion gap metabolic acidosis. On top of that, if they get ketoacidosis, you will get anion gap metabolic acidosis. So they can coexist. And you suspect that if the drop in bicarbonate is much more than the rise in anion gap. On the other hand, if the drop in bicarb is so small compared to the rise in anion gap, then you have metabolic acidosis and metabolic alkalosis. This seems counterintuitive. How can you have metabolic acidosis and metabolic alkalosis at the same time? Well, you can. For example, someone with diabetic ketoacidosis who is throwing up a lot. This is a common situation. You can have both. Now, when you look at the formula here, it's measured anion gap minus 10 divided by 24 minus measured serum bicarbonate. If the measured serum bicarbonate is above 24, then you are going to have a negative delta bicarbonate. And that would be obvious. Then you have metabolic alkalosis in addition to the metabolic acidosis. Now, step 5. You don't need this step unless you are dealing with non-anion gap metabolic acidosis and you don't know exactly what's going on, okay? I'm not going to do step 5 if I have someone with diarrhea, okay, because I know what's going on. I'm likely to do this if I'm suspecting renal tubular acidosis. Okay, now I have to tell you something. Everything we're going to talk about in step 5 with all the complexity is because labs don't measure urinary ammonium. They're more than happy to measure blood ammonium, like someone with hepatic encephalopathy. For some reason, they're not willing to measure the urine. And there are many methods to do it. There are articles on that. Now, nephrologists are lobbying to get the labs to do it. Because if we can measure urinary ammonium, everything I'm going to talk about, all these formulae that are not very accurate anyway, will not be needed. Because in diarrhea, urine ammonium is elevated because the kidneys can acidify. And on the other hand, if you have, say, distal renal tubular acidosis, the kidneys cannot acidify. And by definition, you have low urine ammonium. So if we can measure urine ammonium, we won't need any of that. Okay, since we can't yet in most laboratories, unless you're lucky and you're at a big university and an enthusiastic, open-minded lab director, let's talk about that. So, in the urine, the same thing, you have the number of anions equal the number of cations. So, chloride, urine chloride plus unmeasured anion equals urine sodium plus urine potassium plus unmeasured cation. The main unmeasured cation in the urine is, again, ammonium. Okay, so ammonium goes with chloride. Okay, they're friends. So urine anion gap, if you do like algebraic modification of this formula, urine anion gap is urine sodium plus potassium minus urine chloride. And based on this formula, you can estimate urinary ammonium based on the formula on the screen. Again, not very accurate. We measure urine sodium, potassium, and chloride in a random urine specimen. Now, if we have renal tubular acidosis, like distal renal tubular acidosis, by definition, we have impaired ammonium excretion. And therefore, we have a positive urine anion gap, okay? And so in that situation, urine sodium plus potassium will be more than chloride. Now, if you have adequate renal acidification, like diarrhea, you have adequate ammonium, and then you have a 0 or a negative, usually negative anion gap, okay? So this is how we tell them apart. And again, like usually you can easily distinguish from explosive diarrhea from renal tubular acidosis unless the patient is taking laxatives and they're not telling you. Now, here, let's look at three possibilities. So first diagram, we have distal renal tubular acidosis. So here we have a positive urine anion gap. Look on the screen. So you have your potassium, you have your sodium, and then you have the bicarb, and then you have the ammonium. It is decreased by definition in distal renal tubular acidosis. The patient cannot acidify adequately. So when you say sodium plus potassium minus chloride, you have a urine anion gap that is positive, okay? Because the sodium plus potassium are more than the chloride. Why? Because the ammonium is low. Now, in diarrhea, no, you don't have that issue because the ammonium, as you can see, is up. This is the middle diagram. And then you have, in that situation, you have a negative urine anion gap because the chloride is up, because the ammonium is up. Therefore, sodium plus potassium are less than chloride. Now, you have a special situation when you have toluene toxicity, someone who sniffs glue, and toluene will be metabolized, and you have hippurate in the urine. Here, ammonium is high, but the problem is ammonium is not being excreted with chloride, it's being excreted with hippurate, so you have a zero anion gap, so it will appear as if you have renal tubular acidosis, but this is not the case. So you have a zero anion gap, or even a positive anion gap because of the hippurate. Urine anion gap is misleading in ketonuria, okay, due to ketones, or toluene toxicity due to hippurate, okay, because here instead of the chloride accompanying ammonium, you have ketones and hippurate. Or in any situation where you have inadequate delivery of sodium, in that case you can give some saline, then urine anion gap is not very accurate. Urine sodium has to be above 25 milliequivalents per liter. A better way to estimate urinary ammonium is to calculate urine osmolar gap. So what you do, you order urine osmolar gap. That's a very easy test. Then you calculate urine osmolality. So you get your sodium and potassium in the urine. You multiply that by 2. Urine glucose by 18. If you don't have any glucose on the dipstick, then the value is 0. Then you get your urine urea nitrogen, and you divide that by 2.8. If you are in countries where they use international units, you don't need to divide the glucose or the urea by anything. You just plug that in. And the urine osmolar gap will be measured urine osmolality minus calculated osmolality, and about half of that will be ammonium. Again, we're doing this whole game because we cannot measure ammonium directly. If we can measure it, we don't need any of that. A large urine osmolar gap can be a clue to a missing anion, such as benzoate and hippurate, like in toluene toxicity. I think in this instance, if I'm suspecting toluene toxicity, someone comes in and initially they have an anion gap metabolic acidosis turn into non-anion gap metabolic acidosis. They have problems with their mental status. They're not admitting to sniffing glue. I calculate urine osmolar gap, and when it's elevated, it's really very useful. Now, normal urine osmolar gap is about 100. Half of that approximately is ammonium. And like we said, the osmolar gap is going to be low in renal tubular acidosis because half of that is ammonium, and is going to be high in conditions like diarrhea. They did a study and they found that urine osmolar gap is better in estimating ammonium, urinary ammonium, than urine anion gap. And it's better if hopefully in few years we'll be able to measure ammonium directly, and then we don't need this step. Finally, and this step is very important, if you're suspecting a toxin, if you have someone, you think they've taken methanol, ethylene glycol, you work in the emergency room critical care unit, and you get someone with severe metabolic acidosis, you need to calculate the osmolar gap. So you order serum osmolality, and then you calculate osmolality. So you get your sodium times 2, your BUN, you divide it by 2.8, your glucose by 18. If you have international units, then you don't need to divide by anything. And then you calculate the osmolar gap, okay? Normal osmolar gap is 10 to 15. It's higher in renal failure. If you get a large osmolar gap, if you get 50, 45, then you may have methanol or ethylene glycol toxicity. You can order those, and you need to start treatment right away with fompizole. If you have problems with mental status changes, definitely you need to do immediate dialysis. Okay, this lecture went a little bit long, but I could not cut it short because I had to go through all 6 steps. In the next lecture, we are going to provide examples on everything we talked about, so make sure to tune in. Thank you very much.